We're really fortunate to have Ms Veneman here tonight. We got to know her at the Goldman School a little later than Bill. She came here as an MPP student in one of our earliest classes, graduated with a Master's of Public Policy in 1971, went on eventually to also get a degree in law at Hastings. Her career is quite exceptional, and it's exactly the kind of career that we hope our students will have, that put together public service and public policy, make the world a better place. Forbes recently said that she was one of the 100 most powerful women in the world. That's impressive. Yes. Now, you might think I'm biased towards Anne because she's one of our graduates, and of course I am, as I am towards all of our graduates, but it's interesting to hear what somebody who worked with her in California and who's an astute observer of governance and governing says about her. Elizabeth Hill worked with Anne when Anne was California Secretary of Agriculture, and she says this about Anne. Anne's appointment as the 27th Secretary of the United States Department of Agriculture, she went on from California to be head of the USDA, was historic. She managed a department of 111,000 people, a budget of more than $110 billion. She demonstrated her leadership skills combating mad cow disease and avian influenza, reduced trade barriers, and expanded agricultural export markets. Her legacy included new approaches to help feed the hungry around the world, an important experience which later became important in what she's doing now. Anne's breadth of experience serves her well as the Executive Director of UNICEF. She has visited over 60 countries to monitor her agency's work to assist children. From her days as a BART staff attorney through her international leadership at UNICEF, Ms Veneman has been a problem solver, a leader, a voice of reason and compassion, and a true public servant. That's a little hard not to be impressed by that kind of testimony from the hard-nosed former head of the Legislative Analyst's Office here in the state of California. At UNICEF, she directs an organization with these premises. Children have rights. The world has set goals for their children. Children demand a voice. Poverty reduction starts with children. The people of the world say yes for children, and children should not be dying from preventable causes. What an extraordinary mandate. What a great cause. What an impressive director. It's my pleasure, great pleasure, to introduce to you Ms. Ms Veneman, the 5th Executive Director of the United Nations Children Fund.
Well, thank you very, very much, Dean Brady, for that wonderful, wonderful introduction. I'm delighted to be here, and I want to thank you. We only just met in Washington, D.C. recently, and I was very honored to have your invitation to come here. I also just want to thank Liz Hill for her kind words, even though she's not here. What you don't know is not only did we both go to the Graduate School of Public Policy, but we were high school classmates in Modesto, California. I am truly honored to be here tonight and to be asked to give the Rhoda Goldman Health Lecture. And it's a special honor to meet the Goldman family and to have them here with us tonight. Doug Goldman and your twins. I was told one son was coming, but we got two for the price of one. It's wonderful. They're graduating this year from UC Berkeley, Matthew and Jason. Well, we're here tonight to talk about health, and health is a very critical component of what we do at UNICEF. This is an organization I've been privileged to work with for nearly 5 years now. I thought I'd give you a little bit of background on UNICEF before I started talking about some of the health issues that we deal with. UNICEF is an organization that started over 60 years ago in the aftermath of World War II. Its mission at that time was distributing food and other emergency assistance like blankets and clothing to children in Europe and Japan. One of the recipients of that assistance was one who went on to be one of our most famous Goodwill ambassadors, Audrey Hepburn. And she continued to champion the cause of the work of UNICEF because she herself was a recipient of the help of UNICEF as a child in Europe. Today, UNICEF has an expanded and broader mission. We work in more than 150 countries with about 11,000 employees all over the world in the areas of health, of education, and of protection of children. Protection issues like child labor, trafficking in children, sexual violence, violence against children. All of these are areas in which UNICEF works. But health is a major part of what we do. We invest about $2.8 billion every year in health programs around the world. This is over half of our total budget. UNICEF is the largest procurer of vaccines in the developing world, where we do a lot of procurement of many of the things that help build healthier communities in the developing world. As you know, health underpins many of the globally agreed objectives called the Millennium Development Goals. Now, these goals were agreed to by all the countries of the world in the United Nations and really set common standards around which the world is trying to accomplish certain things, like improving child and maternal health, reducing HIV, AIDS, malaria, and other diseases, improving nutrition, and increasing access to clean water and sanitation. One of the measures of global progress in children's health is what we call the under 5 mortality rate. That is the number of children per 1,000 who die before their 5th birthday. Studies show that countries with lower rates of under 5 mortality experience greater economic growth and poverty reduction. In the past 50 years, since around 1960, the rate of under 5 mortality globally has been reduced by more than 60%. Now, this progress has been made by a variety of things, but particularly preventative measures such as vaccines that have been made widely available around the world. Today, around 82% of the world's children are vaccinated against basic childhood diseases. I think the number back in 1960 was around 20%. So you can see that the reduction in child mortality has really followed the preventative measures that have been taken and extended to children around the world. Some diseases, like smallpox, have been completely eliminated. Polio is now on the brink of eradication. In 1988, there were 125 polio endemic countries. Today, there are only 4: Afghanistan, Pakistan, India, and Nigeria. The other area that there's been tremendous progress is reducing the number of childhood deaths related to measles. Between 2000 and 2008, the number of children under age 5 who died from measles has been reduced by 92% in sub-Saharan Africa alone, between 2000 and 2008, a 92% reduction. This is due to a concerted effort to boost the number of children who are vaccinated against the disease. Another disease of the developing world, malaria, long ago eliminated in this country, but was a major killer in this country, particularly during the times of our founding fathers. This disease still impacts many, many people in the developing world, especially in sub-Saharan Africa. But now with something called insecticide-treated bed nets, we can protect people against malaria and the number of these that are being distributed has accelerated tremendously throughout impacted countries. to slow the spread of the disease. Just to give you an example, global production of these nets has increased from 30 million in 2004 to 123 million in 2009. We are hopeful that there will be universal distribution of bed nets by the year 2010. And as the special representative of the Secretary General for Malaria says, we hope that, and the goal is to have malaria deaths eliminated by 2015. There's many lessons that have been learned along the way. When we began really accelerating the distribution of bed nets, it was thought that give them to every child under age 5 to make sure they're protected because they're at such great risk of dying from the disease. And yet we found that sometimes they didn't reach the children because the adults were using them. And why did the adults need to use them? They needed to be protected from malaria so that they could go to work and earn an income. And so we began to really change the thinking about what needed to be done in terms of distribution, not just the children. You had to cover the family. And by the way, when you cover more people, you prevent the spread of the disease, and the disease begins to decline. Now, of course, some of the gains in global health have been slowed or even reversed in countries where the prevalence of HIV and AIDS has been greatest. This is particularly true in Southern Africa. Because of AIDS, life expectancy in some countries in Southern Africa actually declined from the mid-60s to the low 30s. But with considerable funding available for HIV/AIDS over the past few years, and I mean few, only about the last 4 or 5, through the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and the President's Emergency Fund on AIDS, this trend is beginning to reverse. Globally, over 4 million people were on antiretroviral therapy in 2008. No, I'm sorry, in 2008. That's up from 400,000 in 2003. So that's a huge increase. My first trip to Africa as UNICEF Executive Director was in May of 2005. One of the things that struck me as I was traveling through Southern Africa, I was in Swaziland and Malawi, were the number of roadside coffin manufacturers. Today, you don't see that nearly as prevalent as you once did because of the number of people who now have access to the life-saving drugs. So this trend has begun to reverse, but it has been a very difficult road, and it's certainly one that is not finished yet. AIDS continues to spread, particularly through intravenous drug users, and in one of the groups that you see the highest number of increasing cases is in young women, particularly those that have been subjected to sexual violence in some of these countries. But the good news is with this money that's going into fight AIDS, more women are being tested and treated to prevent the transmission of the disease from mother to child. Access to what we call PMTCT, Prevention of Mother-to-Child Transmission services, has increased significantly, allowing mothers to be given treatment to prevent HIV from being passed to the child. Because more than 50% of the children who contract the disease from their mothers die before their second birthday. But the good news is that more children today are tested and treated with antiretroviral therapy. Children on ARVs increased 39% from 2007 to 2008, 39% in 1 year. While we often hear about malaria and AIDS and some of these other diseases, many people don't recognize that the top 2 killers of children under the age of 5 are pneumonia and diarrhea. Together, these 2 causes of under 5 mortality make up 40% of the overall deaths. Pneumonia is easily treatable with antibiotics at the cost of only around 27 cents for an appropriate course, and yet too many children don't have access to these life-saving drugs at the community level. Diarrhea is often the result of lack of clean water and sanitation. These are major problems that continue to persist in the developing world. Despite gains that have been made, there are nearly 1 billion people in the world who lack access to clean drinking water. Nearly 40% do not have access to improved sanitation, i.e. toilets. In India alone, 58% of the population practices open defecation. Prolonged diarrhea causes malnutrition and stunted growth in children. Yet diarrhea is easily treated with a simple solution called oral rehydration therapy, or what's referred to as ORT. And along with zinc, these two costing only about 30 cents per treatment can really help to save so many children's lives. As I said, diarrhea is linked to malnutrition because it saps the system of adequate nutrients. And inadequate nutrition remains a significant problem in many, many parts of the developing world. It is estimated to contribute to around 1/3 of this under 5 mortality, of the child deaths. What do I mean by contributing? It means that if a child has malaria and also is malnourished, it's more likely that that child will die from the malaria and the combination of the malaria and malnourishment. One of the insights that has been learned over the past few years is the importance of early childhood nutrition. Of particular concern are children under the age of 2. If a child does not get adequate nutrition between the time of conception, that is, ties into the mother's nutritional status, and the time the child turns age 2, it is much more likely that a child will have diminished cognitive ability. And this is over his or her lifetime. So it impacts the ability to learn in school and earn as an adult. This then perpetuates the cycle of poverty. Now, this is something that when I was in the U.S. Department of Agriculture, we recognized as one of our most effective programs, the Women, Infants, and Children program for pregnant and lactating mothers and young children. But this is more and more now being recognized as a key ingredient of what needs to be addressed, linking to overall poverty reduction in the developing world. One of the most important things that can be done to help the child's nutritional status in those early years is what we call exclusive breastfeeding for the first 6 months. Because of the problem of lack of clean drinking water, which causes diarrheal diseases in so many young children and can lead to death, breastfeeding is a proven strategy to give infants a better chance of survival. It is estimated that an additional 1.3 million lives could be saved if the rate of exclusive breastfeeding were increased to 90% in the developing world. But many countries, for a variety of reasons, have surprisingly low rates of exclusive breastfeeding. About a year and a half ago, I traveled to Sierra Leone, a country that has come out of years of conflict, and it's the lowest country on the UNDP Human Development Index. In other words, it's the worst off. It had one of the highest rates of child mortality in the world, one of the highest rates of maternal mortality. And one of the things I learned was that the rates of exclusive breastfeeding were only at about 10 or 11%. And I said, well, my goodness, these people are so poor they can't possibly afford formula. What do they feed the children? They fed them rice water. It's no wonder that so many children were malnourished. So there are many things that can be done to help mothers, help young women in the developing world understand how they can better ensure the chances of their child's survival. Lack of iodine as well. This can result in lower IQ of up to 13.5%, and yet the simple solution is iodizing salt, another thing that UNICEF has worked on around the world. Many other micronutrients provide tremendous benefits at a very low cost. Vitamin A supplementation at the cost of only about 2 cents per dose helps protect against infection and disease. And iron, of course, necessary for brain development. One of the strategies that is proving effective in delivering micronutrients is the fortification of staples like wheat and corn. And this is or corn flour, I should say. And this is gaining momentum and helping to improve micronutrient intake of folic acid, zinc, and iron. Now, over 1/3 of the nearly 8.8 million children who died in 2008, that was the under 5 mortality number for 2008, died in their first 28 days of life. The causes of death include infection, premature death, and low birth rate, and of course, lack of clean water, and a variety of other things. And so when you look at these death rates in those early days, you see how inextricably linked the health of the child is to the health of the mother. If a woman is in poor health, if she's inadequately nourished, if she has HIV or lacks basic medical care, it is more likely that the health and survival of the child will be impacted. So addressing maternal health and mortality is critical and very linked to addressing child health. But addressing maternal health is one of the 8 Millennium Goals, but it is one for which inadequate progress has been made. It is probably one of the most difficult in terms of making progress. It is estimated that around 500,000 women die every year of maternal-related causes. The primary causes are hemorrhage, sepsis, and obstructed labor. But for every woman who dies, another 20 suffer from serious maternal-related injuries, such as fistula, chronic infection, infertility, and incontinence. Too often, women lack access to reproductive health services, prenatal care, or adequate nutrition. In some places, husbands simply do not allow their wives to visit a doctor. There are still around 38% of deliveries globally that are without a skilled attendant at birth. That percentage increases to 61% in the least developed countries. Girls who give birth before the age of 15 are 5 times more likely to die in childbirth than women in their 20s. A mother under the age of 18, if a mother is under the age of 18, her infant's risk of dying during the first year of life is 60% greater than that of an infant born to a mother older than age 19. Because of the risks associated with early pregnancy, it is critical that harmful practices, such as early marriage and female genital mutilation or cutting and sexual violence, be viewed as health issues. Millions of young girls are forced into marriage at very early ages, some as young as 7 or 8 or 9. Last September, a 12-year-old girl from Yemen died in childbirth along with her child. It made international headlines. She'd been forced into marriage with a man twice her age. More than 50% of girls in rural Yemen are reportedly married before the age of 15. One of the cases that also made headlines about 2 or 3 years ago was a little Yemeni girl that was 9 years old. She took the money that she'd been given by her family to go out and buy some bread and took a taxi to the courthouse where she'd been told she could get out of her marriage. She came to visit me in New York because she won, along with her lawyer, a human rights award, and she told me her story about how she was forced by her family to marry a man 2 or 3 times her age, that she hated it, she wanted out, she wanted to go home, and an aunt told her about going to the courthouse, which she did. A judge finally saw her, gave her this wonderful woman, human rights lawyer, and she was actually able to get a divorce and became internationally known for fighting against this practice. But as I said, maternal health problems are also exacerbated by harmful practices such as female genital cutting. Amnesty International estimates that 130 million women around the world have been subjected to some form of this practice, usually when they were young girls. This is a procedure that's extremely painful. It can result in prolonged bleeding, infection, infertility, and complications during childbirth, again related to maternal health. So it increases the risk of maternal death or injury. As I said, girls, too, and young women are often the victims of sexual violence, especially in the developing world. A recent study of young women in Swaziland revealed that 1/3 had experienced sexual violence or coerced sex as a child. This causes early pregnancy, maternal death. It increases the incidence of HIV and AIDS in young women, and of course, it increases school dropout rates. When you look at education, it is critical to improving health outcomes. For every year of additional schooling, a mother's mortality is significantly reduced, and the infant mortality rate of her children declines by 5 to 10%. More years of education provides greater opportunity for income generation and therefore poverty reduction. It also delays the age of marriage and reduces the number of children a woman is likely to have. Access to health care, along with access to education, is key to reducing poverty in the developing world. It took the US about 55 years for infant mortality to be reduced from 175 per 1,000 live births to 75 in 1925. Malawi achieved the same reduction in just 30 years, from 172 in 1977 to 72 in 2007. This, again, is due to the preventative measures like vaccinations and basic health care that have been made to people in the developing world. But there are also many new innovations that are reason for hope. New vaccines still coming online, particularly those that are being introduced now to address the 2 biggest killers of children, including pneumococcal for pneumonia and rotavirus vaccine for some diarrheal diseases. A vaccine for malaria is under development, and promising work is also being done on AIDS vaccines. But there's also innovations involving information technology that are showing tremendous potential to help address some of the health issues. The mobile phone, everybody said it's going to be the World Wide Web that transforms the world. In fact, the mobile phone is the communication tool of choice in the developing world. Between 2000 and 2008, the number of mobile subscriptions surged from 54 million to almost 350 million in Africa alone, an increase of 550%. There are now more cell phones in Africa than in the US and Canada combined. Now, why am I telling you this? Because mobile phones are being used for collecting information, disseminating health data from remote African villages, allowing supplies to be deployed, allowing people to understand if there is an outbreak of disease, to understand if there is increasing malnutrition in an area. So with mobile technology, you can get this real-time information provided on disease outbreaks and malnutrition, allowing for the life-saving food and medicines to be more quickly deployed. Telemedicine, also another great opportunity, not only to help people in rural parts of the US link to the big university hospitals, as is being done in many parts of the country, but now it's helping to link hospitals in the developed world to those in the developing world, and will provide access to more people. But there are many, many, many impediments to progress as well. Conflict countries, the Democratic Republic of Congo, over 5.4 million people have died in that conflict, making it the deadliest war since World War II. It is a very difficult place where conflict continues, where the rapes and the abuse of women, particularly in the eastern DRC, is beyond what anyone can imagine. And I've visited there twice and plan another trip soon. There's also the problem of urban versus rural. Not only do we have an issue in this country of doctors not wanting to practice medicine in the rural areas, and so they all flock to the cities, but you have this problem all around the world, even in the poorest countries where the doctors would rather work in the cities. There's also many countries with a lack of infrastructure, roads, and so forth to transport vaccines, et cetera. Bad governance, corruption, all of these impact the ability to deliver basic services like health care. While I'm on that issue, I want to just say a few words about Haiti, because it has been in the forefront of the news and is such an important issue. I was there 2 years ago. I must say I was shocked to see, even though I've been all over Africa, to see a country this poor 1 hour's flight from the United States, from Miami. And so when the earthquake hit, it hit not just anywhere in the country, but directly under the capital city. So the government, which was already very weak, every ministry was destroyed, the presidential palace was destroyed. 80%, I was told, of people who worked in the health ministry were dead. They have a long way to go to rebuild. Before the earthquake, only 53% of the children were vaccinated against basic childhood diseases. Now remember, I told you that the worldwide average now is 82%. Their education, 50% of the children before the earthquake in school. Around the world, the average is about 80 to 85% now. Less than 60% of the people have had access to clean water, and only 19% of the population had access to improved sanitation before the earthquake. Now there are so many people who have no homes. The schools have been destroyed, healthcare centers have been destroyed, and many lives will be permanently impacted because of the injuries that people sustained. I stayed when I was there this last time, about 3 weeks ago, in Santo Domingo, because it was the hotel I stayed in the last time was the Montana Hotel, which of course was destroyed. And I visited the children in the hospitals. I just never imagined seeing so many children who had amputations, who will never get their limbs back from the earthquake. Now it's the rainy season, and of course the shelter, the sanitation issues become even more difficult and urgent. Globally, life expectancy has increased more over the past 50 years than any time in history. And global health is getting so much more well-deserved attention and investment, whether it's from the Gates Foundation or many countries or the global funds I was talking about to fight AIDS. Now, much more must be done to focus on the countries that are lagging behind. Poverty alleviation and economic development are directly linked to the health and well-being of the people. So from addressing HIV/AIDS to polio, to malnutrition, to measles and malaria and other tropical diseases, investments are paying off, but more investment is needed. The success will be measured in lives saved and lives improved. Thank you very much.
How should the U.S. and European Union agricultural subsidy policies be changed to decrease poverty in the developing world and to help those countries develop an indigenous agricultural capacity instead of being sort of competed out by the very cheap American products that are subsidized?
Well, I think that's a multifaceted question, which probably I could take the rest of the time talking about. But I think that it is very important that the Doha round make progress and be completed, and that address the issue of the most trade-distorting subsidies, which are those that hurt the countries who are producing. Now, I think that, and I think that there has been a growing protectionist view, not just in the US, but throughout the world, which is delaying even further the progress to be made in trade negotiations. So I think that's very difficult in terms of reducing the subsidies, because they do need to be reduced. They do, especially the most trade distorting, hurt those in the developing world. But when you say that it keeps the cheap food, one of the problems is that the world has become used to food prices at the levels that they have been at. And so about 18 months ago, the world experienced increasing food prices, along with the increasing fuel and then the financial crisis on the back of that. And the increasing food prices really impact the world's poor the most. I think the real question today is how do we really create sustainable food systems throughout the world, sustainable agriculture throughout the world? Because I will tell you, as I've traveled around, particularly some of the poorest countries of Africa, their agriculture has gone downhill. The investments haven't been there. The extension systems have gone down. The food aid has been so great that it has reduced the production in the developing world. And I think we have to begin to rethink food aid policies in terms of the kind of, the amounts that we're giving, and purchasing more of the food aid from the farmers in the developing world themselves so that they get the benefit of the production.
You said that early marriage should be thought of as a health issue. What's the best way to prevent or decrease early marriage, and also to prevent sexual violence, which is often related to that, but also obviously related to other factors? What specific programs can you point to that you think have worked exceptionally well in that regard?
I think you have to engage traditional communities. There aren't necessarily one-size-fits-all approaches to fixing some of these problems, because it depends upon the community you're in, the kinds of practices and the reasons for people engaging in early marriage. I mean, in some parts of the world, early marriage really is a way to earn income, because you get so much money in dowry for your girl child. And so it becomes an economic issue. So there are some economic incentive programs where development programs actually pay families to keep their child in school. I mean, education is critical. Making sure it's available and then making sure that girls stay in school. That's one of the best ways. But a lot of the cultural practices also have to be addressed. And to do that, you really have to understand the specific practices in certain countries and communities so that you can address them from their roots. And it has to be an engagement of the community itself. One of the most successful programs that's addressed many of these issues, but particularly female genital cutting, has been an organization called TOSTAN, that's T-O-S-T-A-N if you want to look it up on the web, which is based in Senegal. And they really took a community approach where they began, first of all, working with the community leaders, i.e. the imams, and they educated them on the health impacts of these practices. And once they realized they may be hurting their women and children, they began to look at it differently. And as a result of this engagement, taking a human rights approach to engaging the community as a whole, they've seen better outcomes in terms of health, of education, of attended births. The whole community approach tends to create real, sustainable, long-lasting impacts and change of the practices.
On to another topic. Someone says here, when I worked for UNICEF, I was not allowed to purchase locally produced children's food and had to purchase from U.S. producers. Has this policy changed in the last 40 years? And then related to that, infant formulas, what can be done to get companies like Nestle and others to do a better job of, well, to not so much encourage people to not do breastfeeding, but instead to use their products? Is there something that UNICEF can do that can be done to help solve these kinds of problems?
First of all, on the purchase of food, we don't purchase a lot of food for food aid in UNICEF. We purchase primarily, the products we use are primarily ready-to-use therapeutic foods for treatment of severe acute malnutrition. But the World Food Program had traditionally been using, U.S. product and other developed country product for food aid. That policy has changed significantly. There is much more purchase now of locally produced food for food aid. So, for example, food that's produced in Africa for some of the African countries. There still needs to be a tremendous investment in local agriculture to ensure that people can produce food and not be dependent upon food aid. So I think that, the real critical question is how do you give people the tools to actually produce the food or the income to purchase the food from those that are producing it. The infant formula issue is a very difficult one. Around 20 or 30 years ago, I don't exactly remember the date, there were a number of issues with infant formula manufacturers promoting their product in the developing world. The problem was one I described in my opening remarks, and that is lack of clean water. And so people were mixing infant formula with unclean water, creating diarrheal diseases, creating infant deaths. As a result of that came the Code on Breast Milk Substitutes, which pretty much guides companies today in terms of their advertising. There are still companies who, this says you cannot advertise breast milk substitutes for children under the age of what, but basically it is to protect against these practices. And I think you've seen a tremendous change. There are still problems around the world, but there's been a tremendous change in this practice among those who have the formula companies. And so, sometimes obviously there's no alternative, but you have to make sure people know how to properly use it. But breastfeeding is something that UNICEF promotes extensively. When I was in USDA, even with the Women and Infants and Children program, the USDA started promoting breastfeeding extensively as well, and so that it wasn't just about formula, it was about how to get more people to breastfeed, because that is the healthiest thing for the child and helps to promote health and well-being.
Why did then mothers or the society in Sierra Leone come to abandon breastfeeding, and why are there so many societies in which breastfeeding, exclusive breastfeeding, is so low?
Well, it's interesting because one of the other things I learned about Sierra Leone, about that practice of rice water, is rice water was actually promoted some years back as a treatment for diarrhea. And so there may have been, I don't know, I haven't looked at all the anthropological studies in terms of why this happens in Sierra Leone. It was just interesting to me that it was happening and what they were feeding the children. But I think that, you know, we have done some work. We have been now working with some communities in Central Africa in actually taking young mothers and having them breastfeed their babies in areas where breastfeeding is not very prominent, and then having the women show other mothers how much healthier their babies are, particularly those that are about to deliver, than other babies in the community. And this has been quite effective because it actually takes, you know, the mothers themselves to train others. And I think this is the kind of community-based approach that will create more sustainability of the change.
Turning to another topic, just with worldwide recession and difficulties that many countries are having, there's probably a stepping back in terms of providing aid to other countries. At the same time, the Gates Foundation has taken an increasingly big role in this area. What do you see the future in this area? Is this a temporary turn down? Is the Gates Foundation, in some sense, not purposely, but inadvertently crowding out other efforts? And so what exactly does the future look like with respect to efforts to try to solve some of these health problems you talked about?
Well, I don't think it should be seen as crowding out. I think that there has to be a concerted effort on the part of all sources. I mean, first of all, you have to think about how can you make some of these programs sustainable over the long term? How can you ensure access to basic health services? And the Gates Foundation, I think, has done tremendous work in terms of investing in some of the areas that have not been invested in by others in particular. They have put a tremendous amount of money into research for vaccines for diseases that are not of the developed world. They've put a lot of money, for example, into the research going on malaria vaccines. It's not something our drug companies are going to do in this country or in Europe because these are not diseases of the developed world today. So I think the Gates Foundation deserves a huge amount of credit for that kind of investment. They've also done a lot of investment in AIDS vaccines. But they are looking at, you know, better data evidence. They're also investing directly in programs. They've put a huge amount of money recently into polio to that. I don't know if any of you saw the movie, The Final Inch, but we are at that kind of final inch to eradicate polio around the world. And they, along with Rotary and UNICEF and others, have put quite a lot of effort in the last couple of years to try to make that final inch on polio. They're doing quite a lot on nutrition now. They also have teamed up with the Rockefeller Foundation on a project called AGRA, which is investing in agriculture development in the developing world to address the food issues we were talking about. So it's not, for me, a matter of crowding anybody out, because there's plenty of poverty to go around, and the more investment that can be made in empowering people and making a difference. I mean, I think that there are other models that need to be looked at that have been very successful, like Grameen Bank and Mohammed Yunus, who won the Nobel Prize a year or so ago. I mean, these have been some of the most effective in terms of microcredit, microloans to women in particular. They are now actually loaning. They've been around long enough now that the women who they loan to, whose kids then went through school because they could afford to send them, they now have a college loan program for their children. So there's been, these kinds of successes in development as well, empowering people to really create income generation to support their own families, and particularly women. It's projected that women spend about 70% of their income on their families. Men spend about 30%. Just FYI.
You're someone who, since you were a 1971 graduate of the public policy school for a long time.
You don't have to remind people.
I'm sorry. I was going to say that since you graduated 40 years ago, but I decided not to say that because I thought that sounded worse. So I'm sorry. It was 39 years ago. But you're someone who, throughout that period,
Not old though, because I graduated
because you
early.
graduated very early from high school, and that's true actually, but not well anyway. 5 years old, it was amazing. So you're someone who has worked hard to protect women and to deal with women's health issues and other issues. Let's face it, it's still a man's world out there. What's it like being director of UNICEF, talking to high-ranking figures in governments who are men about these issues? What's the reaction? Do they treat you respectfully and like, oh, isn't that nice? Or is there really an understanding of how fundamental these issues are for those societies and for the well-being of their society?
I agree with you that there is still a huge amount of gender discrimination and lack of opportunity for women around the world. I do think, though, that when you actually address issues as connected to economic empowerment, harmful practices being related to health, I mean, I think you can actually have the discussion on a different level. And, I don't find it difficult to have these discussions because women are half the population. If you don't address the issue of women, you're not addressing the issue of half the population. I mean, the new book, Half the Sky, I think makes that point very well. And I think there's more and more focus today. I mean, I would say that in the last 18 to 24 months, there has been more development focus on women, on adolescent girls, on maternal health and mortality. I've been going for the last 5 years to the World Economic Forum in Davos. I mean, 5 years ago, the issues of women could not make it on the agenda. Last year, I was on a panel within the actual plenary, not an outside panel, that was addressing women. This year, I actually was on a panel at the World Economic Forum addressing the issue of female genital mutilation, if you can believe that, at that meeting. So, there's much more focus among people who you would normally think would not even approach some of these issues. So I think that we are beginning to make progress. They are getting on, at the General Assembly this year, which is a September week in the UN in New York, for the first time, there were a number of events, side events, panels addressing women in agriculture, sexual violence. And so I really do think that these are issues that now are getting into the forefront of the discussion of development in particular.
Okay, so that's great. That says that maybe policymakers are seeing that they've got problems and they want to solve them. How do they react to what I take to be your social, structural, cultural, sociological analysis that says a lot of these problems are deeply rooted in marriage practices, in educational practices, in a lot of things that are very fundamental to a lot of societies and not easy to change and not the kinds of things that most policymakers want to take a run at?
Well, I think education is fundamental, and as we were talking about earlier with the students, one of the dramatic changes, particularly in some of the developing world, has been a policy that UNICEF has been very proactive in supporting, as have another number of other organizations, and that is elimination of school fees to ensure free primary education. The practice has been that if you have several children and you can't afford the school fees to send all of them to school, you'll send your boys and not your girls. Well, once you eliminate school fees, then you tend to create more access for girls to go to school. I just read an article, I was surprised to read this, that in Uganda this year, they graduated more girls than, or more young women than young men from the university, which I found amazing.
Let's take a particular area, which is family planning. What does UNICEF do in that area, if anything, and how does it do it, and what kind of political realities must it face?
UNICEF does not do a lot in direct family planning, as that is done primarily by what's called UNFPA. But UNFPA is a strong partner of UNICEF. They primarily work on the reproductive health issues, but as I said, the health of the mother is inextricably linked to the health of the child. And so we work a lot in partnership with them on a number of these issues. While we don't, we aren't purchasers of contraceptive products, we certainly support women's health centers, particularly, for obstetrical care and so forth. So, with these strong links, and certainly UNFPA has had its difficulties with some of the allocation because they are directly involved in these issues. And so sometimes the allocations from governments. One of the things to understand about UNFPA, the World Food Program, UNICEF, and something called the UN Development Program, unlike the rest of the UN, we are voluntarily funded programs. We get no dues from the United Nations, zero. Whereas something like the World Health Organization or the Food and Agriculture Organization are member organizations, and countries pay dues to belong to them. So we get money from governments, but it's part of, for example, in our case, the State Department budget that's a voluntary funding as opposed to a dues to the UN or to WHO or to the FAO. So many people don't understand that distinction about some of the international organizations, but we are entirely voluntarily funded.